Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network at the UNC Lineberger Comprehensive Cancer Center. Thank you so much for being here with us today. And I want to go over a few things and then we'll meet our presenter and get started. This is our RN and Allied Health Lecture, June 13th, 2018. If you are having any problems at all with the audio, the video, the slides, please call us 919-445-1000. We'll do our very best to help you out. Good news is not only is this presentation live, but it will also be recorded and will be made available for credit. So anytime within a year of today, you'll be able to go online, log into our portal, watch the lecture, take a brief test, and receive credit that way as well. Please be sure to spread the word on that, and we want to make as many people as possible aware of that. And of course, all of this is free through UNC Lineberger Comprehensive Cancer Center. So we're going to talk about Poll Everywhere in a minute. We have a website, unccn.org, plenty of information there. We're on Facebook, Twitter, YouTube, etc. I hope that you'll take just a moment to use one of two ways to join us via Poll Everywhere. We'll have an icebreaker at the beginning, and then our presenter, Dr. Kuzmiak, has several slides where she'll be presenting different questions which you can answer. This is all anonymous, but we love to have audience participation. It really makes for a better presentation, so please go ahead and log on to Poll Everywhere now. You can go through any web browser connected to the internet to pollev.com/UNCCN. That will get you to the Poll Everywhere site, and you will automatically see the new questions show up. You can answer those questions as they appear. Alternately, and we have a lot of folks do this, you can, on any phone with texting capabilities, in the to field you type in 22333, and in the message field you type in UNCCN. If you'll do that, we'll go ahead and join you to the poll, and then you can answer the questions via texting. So whichever one of those works, that would be great. And here's what that will look like. So again, pollev.com/UNCCN or UNCCN to, you're texting that message to 22333 just one time and you'll be set for the day. All right, so without further ado, I would like to introduce our presenter today, Dr. Sherry Kuzmiak. Welcome.
Thank you, Tim.
Glad to have you here. Rather than read the bio, let me see if we've got this right. So you were appointed, I better put my glasses on to do this. So you were appointed Chief of the Breast Imaging Division and Director of Breast Imaging Fellowship Program in 2005. Mm-hmm. And you've been here on staff at UNC Healthcare since 1999.
Correct.
Great. And we've got lots of honors and research interests that include the interpretation and diagnostic analysis of digital mammograms and digital breast tomosynthesis, magnetic resonance imaging of the breast, automated whole breast ultrasound, dedicated 3D computed tomography, intraoperative radiation therapy of the breast, and breast cancer genomics, all as various areas of interest.
Yes.
Great. Anyone that's your favorite?
Right now, my favorite is actually with breast cancer genomics and the imaging appearance of the different subtypes of breast cancer.
Okay. And co-authored a book, Digital Mammography, with Dr. Etta Pisano and Martin Yaffe. And then we understand that you're the editor of Breast Imaging, and this is from Intech. And
yes, that's correct.
New book, just published?
Just published. It's a collaboration of authors from around the world, so it was a very fun and worthwhile project.
Great, and congratulations on that. What's one thing that we haven't covered that our audience should know about you?
Let's see. Prior to about a year or so ago, I was a competitive triathlete.
Great.
So I'm just trying to stay fit and
all right.
Well, keep upright.
Well, we'll see if we can keep you in one place for the next 55 minutes or so.
Sometimes some of these lectures become, marathon events, and you need that endurance to get through them.
Right. Well, we'll try not to make this too much of a marathon. We do want to remind all of you in the audience, please go ahead And in addition to answering the poll questions throughout the presentation, be thinking of questions that you have that aren't the poll questions at the end, and we'll have an open-ended Q&A at the end where you can share your questions for Dr. Kuzmiak. So far, pink is the one word that's come up. So I'm guessing there are others. If you want to take just okay, friends, many, pink. Karen, so an individual, mastectomy.
Mm-hmm. Komen. Mm-hmm. I actually did my breast imaging fellowship at the Susan Komen Breast Center when I trained before I started here.
Very good.
Great folks. Resources, sibling, aunts.
And one of the things that comes across very clearly with some of the words here is just how many people in each of our personal circles, family, friends, relatives have been impacted by breast cancer. Certainly.
My own grandmother. So that's kind of how I fell into this as a personal.
Really? Is through family?
Yeah, my grandmother, my maternal grandmother.
Okay, and that led to your interest in your
Yes,
field?
it did. So I certainly have my own pink here. So I have my pink jacket on, my UNC, my little ram with the radiology. So, pink is certainly near and dear, is one of the answers to this.
Yeah.
It's certainly a universal bond.
Well, let's go ahead and with that, remember we'll have plenty of questions for you to answer with the polling and breast imaging technologies, cancer detection, and personalized medicine. I'm going to go ahead and
thank you so much.
Turn the controls over to you.
And thank you again for having me. It's a pleasure to be here. So some technologies that we're going to talk about with breast imaging will be mammography, ultrasound, and MRI. So the learning objectives today, there's three. They're pretty simple. List 3 new developments in breast imaging. I already told you those 3, what they are going to be about. Discuss the advantages and disadvantages of the advances in breast imaging and cancer detection. And describe how these advances in breast imaging and cancer detection can be applied to your practice patterns to benefit your patients. So why screen for cancer? Certainly we don't want this. If you see here, she has certainly a normal right breast and a completely abnormal left breast is completely filled with cancer. The nipple-areolar complex is gone. She has this lesion that's basically popping out and going up towards the armpit. And then she has tissue necrosis. We have cancer invading in here. And unfortunately, we still see this. We had a case of this last week. So with screening tests, we can start out with no screening. And if we have no screening, basically the patient can present with a palpable finding. And if we can find the cancer only through palpable means, usually they're a larger cancer. They can be more advanced in the sense of lymph node involvement. The prognosis and overall survival of the patient may actually be less. So if we introduce a screening test, the idea is to detect these subclinical, the ones that are not palpable, so finding cancers sooner, providing a better prognosis for patients. So if we can help prevent these locally advanced cancers, and if we can find a cancer here on this mammogram, here we have a left breast medial lateral oblique view. We'll do a little Mammo 101. Fat is black. Breast tissue is bright or white, and so are masses and cancers, and this is the challenge with breast imaging. So the idea of screening is we can find a small little cancer. Here we have an invasive ductal. This is an irregular, high-density mass. There are associated calcifications that go along with ductal carcinoma in situ. So the goal is to find it when it's small, not palpable, and an excellent cure rate. So why screen for cancer? Small treatable lesions, less therapy, and certainly improved prognosis and survival of the patient. So screening tests, I want to talk a little bit in general about them. All screening tests are like the smoke detector. Is the best analogy. Some of the detectors will detect smoke and go off, and when they detect the fire, the cancer is certainly there as a screening test. And we have some screening tests where the smoke detector doesn't go off, and so there's no abnormality there. We can have where the smoke detector goes off. However, it's a false alarm. We put the fire out with a fire extinguisher, and this certainly can happen with all tests where it's a positive test and further things are done and it's proven that the patient is actually normal. So it's a false positive. And then we can have where the smoke detector does not go off, and it's certainly truly a negative screen, but also we can have where the screening exam doesn't go off, but there's a cancer lurking, so a false negative. So either it's something that the smoke alarm cannot detect, perhaps it's an electrical fire instead of a paper fire, but it's just something they cannot detect. So here's kind of the positives and negatives of screening tests, where we can have the smoke detector go off and there's cancer there. So a true positive, the smoke detector goes off and we put the fire out and it's a actual false positive at the exam. And then we can have where the smoke detector does not go off and that the exam is truly negative, or there's something there lurking and the detector just can't pick it up, and we have what's called a false negative exam. So breast cancer. We have our first poll question here. Breast cancer is blank common cancer in the world. I'll give you a moment to answer it. Is it the most common? Is it the second most common? Is it the 5th most common or 10th most common? As with all test questions, if you don't know the answer, that's correct. Select B. And excellent job by our audience. Very impressed.
And if you're using that texting, just A for most, B for second most, C for 5th most, and D for 10th most. So we're definitely running
very
with
impressed
B.
by the audience. So that is correct. It is the second most common cancer in the world. So it's the most frequent cancer among women. About 1.7 million new cases are diagnosed each year. The incidence and mortality are very interesting. The highest incidence is in North America and Europe, and the lowest incidence is actually in Asia and Africa. And if we look at the mortality is actually highest in the less developed regions. Obviously, lack of health care, lack of access to health care, and just advanced treatments. So if we look at the World Health Organization map, or if we look at the map in the dark blue, is actually the highest incidence. You can see North America, Europe, Argentina, and Australia over here. The lighter blue is less incidence, a lower incidence. And if we look at the mortality, there's actually an inverse relationship between them. So if I toggle back and forth, dark blue here, and then we have kind of the lighter orange, so the mortality is less, and you can see where the darker orange, the mortality is higher. What's interesting is in Argentina, they have a higher incidence and also a higher mortality, so perhaps there's something with the actual breast cancer in the sense of the genomics that's going on there that we just don't know yet. If we actually look in here in the United States, this is information from the American Cancer Society, and looking at the overall deaths. In 2017, it was about 40,000, give or take, compared to the previous numbers, a few more. And if we look at the in situ cases, about 63,000. The number of invasive cases, about 252,000, almost 253,000. So it's interesting numbers if you actually look at the tables, and here we have the ages of the patient. Here's 40 to 49, 50 to 59, and then 60, 69, and then 70 and older. And so if we go across even with the 40-year-olds, you know, the numbers are not zero here for the in situ and invasive cancers for these women between the ages of 40 and 49, and certainly mortality. Women with in the age of the 50, it increases a little bit, and women in the 60s and 70s. So I think it's always important to go back and look at the data and notice that, you know, our patients go across all these age groups. So it's important to know exactly what goes on in overall incidence and mortality. So breast cancer itself is a heterogeneous disease. The cause or causes are unknown. 1 in 8 women in their lifetime, if they live to be in the age of 80s, will be affected with breast cancer. And more than 80+% of the women will not have a family history at the time of the diagnosis. They become their family's history. So who's at risk? Any female with advancing age. So each and every day as we get older, we're at increased risk. Individuals who have genetic mutations, they they're about 5 to 10% of the population, and these are certainly the women who have like BRCA mutations and some other mutations. Women who have a history of breast cancer already, a personal history. They've had breast cancer once, they're at increased risk of developing breast cancer again. Women who've had a high-risk lesion, maybe atypical ductal hyperplasia, atypical lobular hyperplasia, or even lobular carcinoma in situ, and certainly women with a strong family history of breast cancer are at risk. So the first thing we're going to talk about is mammography. So what is a mammogram? A mammogram is actually a specific type of breast imaging that uses low-dose x-rays to detect cancer. So if we look at our schematic here, here's the top of the breast, the bottom of the breast, and towards the nipple where the arrow is pointing. And then we have the fatty tissue, which is the yellow, and then we have the glands, the lobules, and fibrous tissue. And if we look at the mammogram over here as the correlate, fat is actually black, so back to Mammo 101, fat is black, and breast tissue is bright or white, and so are the ligaments. So that's kind of the quick and dirty for the mammogram information. But how is it performed? Two views of each breast. So we actually get a cranial caudal view where the compression is from top down and the x-ray beam actually comes from superior to inferior. In this type of view, the cranial caudal view is actually to get that medial tissue of the breast. And then we have the second view, which is called the medial lateral oblique, or the MLO view. And this is the view where it's about a 45-degree angle where the technologist positions the patient, and the actual x-ray goes from medial to lateral on oblique angle. That's how it gets its name. And the majority of these will detect these cancers kind of in this upper portion of the breast and lateral aspect as well. So breast compression, it's necessary, as you can see in this little cartoon. Yes, I did have my mammogram today. Why do you ask? With breast compression, it's kind of one of those necessary evils. By making the breast as thin as possible, you can actually use less radiation. It helps separate some of the tissues out. It will increase our subject and our image contrast as well, and also decrease motion. Screening mammography. So screening mammography is for a woman who's asymptomatic. She has no lumps, no bumps, no problem. A diagnostic mammogram is for a woman who has a lump, a bump, bloody nipple discharge, or if they get called back from a screening mammogram. So what I'm going to focus really on with today's lectures is talking about some of the screening modalities using mammography, ultrasound, and MRI for personalized medicine. So if we're looking at the women who have less than a 15% lifetime risk, I kind of call these the plain Janes. So looking at for screening mammography, what should be the frequency? Annual mammography at age 40 and up. There are certainly, it's the most benefit is screened yearly. There is confusion with the different recommendations, but I think it's really important as a healthcare provider. Your society may recommend a certain recommendation, but please read the actual articles and the publications that they have, and that you will see, even for women under the age of 50, that women in their 40s may benefit from annual screening mammography. So these are people that you really need to have a discussion with for the risk and benefits as well. What about women at intermediate risk, that 15 to 20% lifetime risk of developing breast cancer? These are the women with a personal history of breast cancer. They've had atypia, they've had lobular neoplasia, so they're already at high risk. So for them, the frequency of mammography would be an annual mammogram, especially if they haven't already had one starting at 40. What about these women that are high risk, our special patients, the one that are greater than 20% lifetime risk? These are the women with a family history, especially premenopausal. They've had a history of chest radiation, especially between the ages of 10 and 30. Maybe they've had a history of lymphoma, mantle cell radiation. Women with genetic mutations such as BRCA and other ones. So these are the ones greater than 20% lifetime risk. So what about the frequency of these individuals? So those with a strong family history, the annual mammogram should begin 10 years earlier than the effective relative at the time of diagnosis, but not before the age of 30. So this is personalized medicine. So let's say your patient comes in and she tells you, my mother had breast cancer at the age of 40. You want to start screening her 10 years earlier, so you would start her screening at the age of 32 as an example. What about the women who've had chest radiation? Annual mammography for them should start 8 years after radiation therapy ends, but not before the age of 25 for imaging with mammography. So let's say that your patient was 20 years of age when she finished her radiation therapy. So you'll start her at the age of 28 as an example. For those who have the BRCA mutation, a couple things I do want to point out. If MRI is not available to your patients wherever you may be located, mammogram beginning at the age of 25 is recommended, and then annually thereafter. However, if you do have MRI available for your patients, annual breast MRI with contrast should begin at the magic age of 25. If you have a patient who has a breast cancer mutation, and she's a little bit older, it would be the annual mammogram and MRI with contrast starting at the age of 30 and annual thereafter. So there you have some options if you do not have MR available for your patients to start mammography at the age of 25 for your BRCA mutations. So what are the advantages of mammography? Mammography has helped reduce breast cancer mortality by about 40% since the late 1990s. It's an acceptable technique for mass screening for breast cancer, the general population. It has an acceptable specificity, where the specificity is you find something on the mammogram, it's a mass. And my ability to determine is that mass going to be benign or malignant is very high with mammography, and such as this example that I showed you earlier. Here we have an irregular mass. It's high in density. Already it's very suspicious for being a cancer, and it has some associated findings, these little tiny calcifications. The other advantage of mammography, it's the only imaging technique that reliably detects calcification, so something else to be aware of. So it has a high specificity that once something is detected to be able to determine is it going to be cancer or not cancer. It's also the most cost-effective, non-invasive examination. The studies are reproducible, so whether you have a mammogram done on the East Coast, West Coast, Europe, Asia, the studies are very reproducible. What are the disadvantages of mammography? Certainly radiation. It's equivalent to one month background natural radiation. So if we have patients who come in and they're scared about having a mammogram because they're radiation phobic, we just basically inform them that, you know, in 1 month time that you would have is just natural background radiation. That's how much radiation that you would get from a screening mammogram. Disadvantage with mammography is the sensitivity, being able to see something, detect something. It has a variable sensitivity, such as in this breast here where we have a dense breast. So dense breast is just you have more glandular tissue, more stroma, this white stuff, versus a breast that's fatty. Once again, fat on a mammogram is black. So here we have a dense breast. Here we have a non-dense breast, completely fatty replaced. So the sensitivity is much lower in these dense breasts, and it's much higher in the fatty breast. So this is where fat is actually your friend, where I'll tell patients where nothing can hide, and we can actually see stuff in the patients with a fatty breast. So if we think about the sensitivity with mammography, we can run into the problem with the false negatives. This is where the smoke detector does not go off. You know, there may be a cancer lurking in here and we just can't see it. So the smoke detector doesn't go off. The other problem or downside with mammography is with false positives, that callback. So this is where the smoke detector goes off, she gets called back, she gets worked up, and we actually put the fire out, so it's a false positive. And so when we look at the false positives kind of in callbacks, kind of to think about, So for every women, the 1,000 women who are screened, about 10% of them will be recalled from a finding from their screening exam. Roughly about 60 of these women will be worked up with, additional imaging and ultrasound, and their exams are normal. About 20 of them will have a finding that's probably benign that needs to come back for a short interval follow-up. Probably benign means less than a 2% likelihood of breast cancer. Roughly about 20 of them will go on to have a needle core biopsy, and depending on your patient population, about 5 of these women that are called back will have a breast cancer. Once again, the other biggest disadvantage with mammography is the actual breast density, the glandular tissue, the stroma, the elements there holding the tissue together. So with breast density, it's kind of like this image here. It's trying to find basically the polar bear in the snowstorm. Some of you may on the second image may be able to see the polar bear, but this is what we run into with women who have dense breasts or more glandular tissue than fat. It's problematic, this phenomenon, trying to find the polar bear in the snowstorm or the cancer in the dense breast is what's called masking. It occurs when the surrounding breast tissue basically obscures the cancer. We have a decrease in lesion conspicuity. It limits the sensitivity of the actual screening test. The smoke detector doesn't go off. And once again, the sensitivity is lower in these dense breasts. The other problem with breast density is you have a higher likelihood of having an interval cancer with more of a dense breast. So an interval cancer is being detected with a breast cancer within that 12-month time period of having a normal mammogram. Also, with having more breast tissue, you have an increased risk of developing breast cancer. So there's something going on in the microenvironment in women with dense breasts that we still really need to do further research and find out the information about that. And certainly folks here on UNC's campus have been working on that. If we look at the breast density distribution, some people are lumpers, some people are summers. In general, half the population is really non-dense and the other half is dense. So here I use yellow as kind of the fatty. So for those, about 10% of the population are completely fatty replaced. The black mammogram, easy to find a cancer, a white mass in here. About 40% of the population is what's called scattered fibroglandular tissue, and this is where there's about 25 to 50% of the white glandular elements seen on the mammogram. And then when we kind of get over the hurdle into the dense breast, the one is called heterogeneously dense. That's also about 40% of the population. And that's when there's about 50 to 75% of the glandular tissue of the white. So these are the patients where I tell, imagine a blackboard and just start throwing a bunch of lumpy oatmeal at it till you almost cover it. That's what a heterogeneously dense breast looks like it. And then the last is the 10% where it's the extremely dense breast. It's kind of the polar bear in the snowstorm or the little snowball. Sometimes I'll explain to the patients, like a snowball, where it's extremely white and it's hard to see in and around and through it. So to understand where we're going in breast imaging, I think it's very important to have an understanding of where we're coming from. And mammography has been around since the early 1900s. The French have always been ahead in fashion, and they've been also ahead in mammography. So here's an example from roughly about the 1940s, where a very crude mammogram machine, and when we go over to the other side, you can see where there's a little bit more housing. They actually used industrial film, very high-dose radiation, and then even in the 1980s and in the era of big hair and shoulder pads and punk rock and other things, we tried to actually, instead of using film, record the mammogram on paper. And it's kind of interesting and challenging, I would expect, as a technologist. Here you have this balloon and an x-ray cassette below and a cushion to try to get this woman positioned in order to get an image that looks like this on the side of the screen. You can see her ribs, the outline of the skin, and just blue glandular tissue. So I think as a reader it'd be very challenging, but especially as a technologist, and also the cooperation involved in the patient in order to get images. And so that was in the 80s, but I can tell you that film screen mammography was also being further advanced during the 1970s. Here we have dedicated equipment for actual breast imaging. We had these things called cassettes. It was kind of like a clamshell, a piece of film went in it. We actually put it into the machine. We x-rayed the patient. We took that cassette out. The technologist ran it into the dark room, actually ran and developed the film. That was actually one of the disadvantages of film screen is the film itself. Whatever image you acquired, that was it. If you lost the image, you'd have to go and take it, or perhaps the image was taken with her folder for an orthopedic resident, and it was taken to another building, and those films were never returned, which has and did happen. But certainly with dedicated equipment, we were able to use less radiation. We had higher contrast. We were able to see more of the glandular tissue, kind of a de-differentiation between the breast tissue and lesions. But certainly the downside of film was the film itself. So to try to get a better image, perhaps we were very fortunate that digital technology came along kind of in the late 1990s. And that's actually one of the reasons why I came to the University of North Carolina is Dr. Edo Pisano was working on digital mammography, so I figured I will go to the institution and learn about it directly. So I'm very proud of the fact that UNC has done a lot of work with exploring women's health care and being a leader in full field digital mammography imaging. And UNC was, I think, the second or third in the country to have one of the digital units. This happened to be the digital unit we had here in a building, the Gravely building that no longer exists. But the FDA approved digital mammography in the year 2000. There was a lower radiation dose than screen film. It was actually about 50% less, so a tremendous benefit that way. We actually had the image recorded as an electronic, if you want to think about it as a data file instead of a piece of film. Here we stored it on in the computer. We could print multiple copies. And now we have the PACS system, the picture archiving systems that we can look at these images. We can manipulate the images just as you would in PowerPoint for your own family photographs. So we can certainly do a lot of things of the flexibility of digital that we couldn't do with film. Basically, the only thing we could do with film was highlight the image over a light bulb. So the digital image can be manipulated for further evaluation, which is a strong part in with digital mammography. There was a clinical trial that was called DMIS, Digital Mammography Imaging Screening Trial, and basically it was comparing the accuracy of film versus digital. So approximately 50,000 women at 35 sites in the United States and Canada were enrolled in this trial. Women underwent a film screen mammogram and digital mammogram on the same day. The images were interpreted by two different radiologists, and neither radiologist knew what the reading was for the other. And if the woman had a finding, whether it was on the screen film or the new digital, she was called back and worked up with standard of care. And from this large imaging screening trial, what we found was the accuracy of digital was significantly higher than film mammography in three subpopulations. And these three populations were women under the age of 50, women who had heterogeneous or extremely dense breasts, and women who were pre or perimenopausal. So here is where the digital technology outperformed the gold standard at that time of film screen for the advancement of women's health care. And I just threw this slide in as a remind you of the BIRADS lexicon that we use, and when you read reports, that about 50% of the population is more towards the fatty end, and the other 50% is more towards the glandular end, where you have more dense tissue. So the dense tissue does limit us, and so using the digital platform, what we've been able to do is advance the technology. You've probably heard it used as the slang term as 3D, but it's called digital breast tomosynthesis imaging. As I explained to patients, it's like taking your breast and then we image it, and it's like looking at like a loaf of bread. I'm able to take out the individual slices and look at the individual slices versus before it was just the single two pictures. Digital press tomosynthesis, we still have x-ray, we still have compression, so we haven't eliminated that for patients. The interesting thing is with the tomosynthesis units, the x-ray tube will move over the top. Some actually move in concert with the detector, and depending on where the object is in the breast, such as in this schematic here, instead of getting a single picture, we get multiple ones. So it depends where the object is in the breast, it'll project at different heights. And what we're able to do is take those multiple images, and then we can reconstruct them into these high thin resolution slices, so we can look at the slices either together or individually. We can put them together, kind of thicken them up as a slab, or we can look at them as a movie and kind of scan through the images, whether it be from a medial to lateral oblique projection or from a CC projection. So basically we're viewing by layers of interest. We're trying to see into the dense part of the breast. We're trying to remove the overlap of the dense tissue. And so the user can interactively look at them individually. They can display them as a movie and scroll how they will through them to try to determine if something is really there. So we're trying to improve our sensitivity. So in 2011, the FDA approved digital breast tomosynthesis. And how the FDA approved it was the woman had to have a 2D study, and then she had the supplemental imaging, the tomosynthesis imaging, and these were reviewed together, what was called a combo mode. Certainly digital breast tomosynthesis takes longer to acquire. There's increased interpretation times with more images to look at. Some examples that I have here, hopefully they'll project well. Here we have the 2D image, CC, and in the center portion of the breast, it looks like there might be a little bit of distortion. Distortion is sort of like you take your fingers, snag a sweater, it kind of bunches up. And then here we have a single slice that we're looking at, and you can see here on the single tomo slice that the distortion is real and there's a small little spiculated mass. This was an invasive ductal breast cancer. Here's another example in another dense breast where there might be something in this deep portion of the breast. And then we have over here the tomo image, and then we can see that certainly on the tomo image on this zoom there is a mass here and there are some spiculated margins extending from it. So once again with tomosynthesis you're trying to remove the overlap of tissue and increase lesion conspicuity. This is one of those interesting and eye-opening cases. Here we have a left breast CC, we have the dark fat, we have the bright breast tissue. She has these big benign type calcifications. Really nothing popped out, and then we did the tomo on her, and all of a sudden you can see over here, we put a little green circle around it, this rather large irregular mass with spiculated margins coming out. So this was an invasive breast cancer as well. So what are the advantages of tomosynthesis? Certainly there's increase of cancer detection in the literature that's out there. It increases invasive breast cancers. It hasn't changed the increased rate of ductal carcinoma in situ, so there's not that over-detection, as some people will argue with breast cancer screening. It increases the positive predictive value. So if you see something on tomo and you call it back, that's the likelihood that it is something, and also has increased the positive predictive value for biopsy. So if you recommend a biopsy from a tomosynthesis study, most likely it might be a cancer versus before where you might have called back many and there was a lower positive predictive value. It certainly decreases the unnecessary recalls. It doesn't eliminate them. No test is 100%. But it certainly decreases them because you may see something on the 2D imaging and you scroll through the movie images and you find that it's just overlap of tissue. She does not need to come back, and since she doesn't need to come back, you're actually saving economic resources for the patient and insurance companies by having not to recall that individual and doing additional workup. What are the disadvantages of tomosynthesis? The machinery costs more than just a regular 2D full field unit. You need larger storage space in packs. It doesn't do well with calcifications with these multiple supplemental imaging. So if you have a mammogram and calcifications are detected, you still have to be called back, and magnified standard of care imaging has to be performed to evaluate the calcifications. Other disadvantages are radiation dose. Although the actual tomo images are low in dose, when you have the combination of the 2D and the 3D study, it does increase the radiation dose by approximately twofold. However, even with the combo mode, the overall dose is still below the FDA safe limits of 3 milligram per view. The radiation dose is cumulative. People have to be cognizant of that over their lifetime, so maybe it's prudent to kind of limit some of the radiation exposure. Larger breasts require more slices, therefore more radiation. I had a patient the other day just on her tomo image. She had 102 slices versus some of the patients that traditionally may have 30 or 40. So you have to be aware of factors such as that. We're trying to help lower the dose by having synthetic images, and this is where you take the tomo images and basically you make a synthetic 2D mammogram out of it. Some of the vendors have done quite well. I still really think there needs to be advancement with the synthetic images. They haven't been proven to completely replace some of the 2D imaging, but at least the vendors are respondent to our pleas to improve some of the imaging and certainly to help our patients by lowering the dose of radiation. So once again, not all cancers are seen with tomosynthesis. There are cancers that are occult. Remember, no test is 100%. So questions we still need to answer. Does tomosynthesis help detect more lethal, more advanced cancers than our 2D full field digital mammography? There's a clinical trial that's available now called TMIS, Tomosynthesis Mammography Imaging Screening Trial. In this study that will be roughly about 165,000 patients, women will be randomized to the conventional 2D, and they'll be randomized to the 2D plus tomo arm, or if the institution is doing tomo and synthetic, and they will have several rounds of imaging. And with this ECOG Akron trial, we're going to look at the advanced cancers. Can tomo outperform our standard 2D in finding more lethal, more killing cancers? We're actually going to look at the genomics of each of the cancers and also look at the genomics of the benign lesions. We're going to evaluate liquid biomarkers in blood. We're going to look at samples from the inside of people's cheeks with buccal swabs. And certainly the idea is to use modern technology to help focus towards personalized imaging in the future. Perhaps what you need is not the same thing that your neighbor may need. Perhaps your neighbor may have a completely fatty replaced breast, but at the same time she may be at risk for increased cancer and certainly needs to be screened annually. You may have a dense breast, and instead of being screened once a year, perhaps with some of these liquid biomarkers, you may only need to come once every other year. So these are certainly questions that still need to be answered. So once again, what tomosynthesis we have to figure out is if these other factors are worth the trade-off of the radiation for our patients. And then the question becomes should we only use it to screen women with dense breasts? All right, so we have a poll question here. All of the following regarding screening mammography are true except. So since it's an except question, you're looking for the one that would be false. So letter A has an overall low specificity in 2D and 3D imaging, has a low sensitivity in dense breast tissue. DBT decreases the limitation of tissue overlap. DBT has a higher radiation dose than 2D imaging. So go ahead and vote.
And again, if you're using a phone to text this in, the first one A, second one B, third one C, and last one D.
I'll give you a moment here.
Yeah, absolutely.
So we're looking for the false answer. And so the answer is actually A. So all the following are true except. Remember that with mammography, 2D and 3D have high specificity. All the other answers are true. A lower sensitivity in a dense breast. DBT does decrease the limitation of overlap of tissue, and DBT does have a higher radiation dose in the 2D. So here we have the dense breasts. Tomosynthesis certainly is the forefront of helping. However, even with tomo, we are limited by breast density. So there is some supplemental screening that I do want to talk about. So here we have the example where we have no screen, one screen, and maybe if we add a second layer of screening, we can find cancers even sooner. And this is where supplemental screening, looking at the general patient population, perhaps women with dense breasts and women with high-risk patients, may actually benefit with the supplemental screening. So with ultrasound, it's an alternative technology that's not limited by breast density. We have that single handheld transducer. There is operator subjectivity. It does take long to do these exams. And limitations in the handheld scanning. You can miss a lesion. There's a lot of things that you can find that are not cancers. They're just benign cysts with debris, fibroadenomas. So there were some early studies out there looking at dense breasts and using ultrasound. And what they found with ultrasound is they can increase the cancer detection rate by roughly about 4 out of 1,000. So it's similar to mammography comparisons. It can detect with ultrasound small early stage cancers that can be occult on mammography, and so stage and mammography are once again comparable. It increases detection of node negative invasive cancers in women in the first prevalent screen, so these are women who have never had that type of exam before. A study that we did called Akron 666, so this was American College of Radiology Imaging Network, about 2,800 women with high risk and dense breasts at 21 sites. They underwent 3 annual screening with ultrasound and mammography. About 600 also underwent MRI. There was 110 subjects. There were 111 breast cancers. And I want to point out from this study that 30% of the cancers were detected with mammography only, about 30% seen only with ultrasound, 23% were seen with both modalities, and about 8% were seen with MRI only, and 10% were not detected by any of the 3 modalities. So once again, no test is 100%. What they did find with this study, though, roughly there was about 4 extra cancers out of 1,000 detected with ultrasound. But the big bonus in these high-risk women was that with MRI, almost 15 cancers out of 1,000 screens were detected. Looking just at the ultrasound detected cancer, 30 of them were invasive out of the 32, about a centimeter in size. Most of them were node negative. Their biopsy rate was about 5%. The cancer detection was about 7.4, so extremely low if you found something with ultrasound. So their conclusion, the additional screening ultrasound or MRI to mammography at increased risk of breast cancer detection resulted not only in a higher cancer detection rate, but also an increase in the false positive findings. So this is something to take into consideration when you think about perhaps supplemental screening with your patients with ultrasound. They may find more cancers, but they may also find more things that need biopsies that lead to false positives. A study that was done out of Connecticut was a retrospective study done by Yale, and this is where technologists did handheld ultrasound. They had 935 patients, 614 were low risk, about 150 intermediate, and 87 were high risk. And what they found that the majority of everything was benign, about 20% probably benign, recommended a short interval follow-up, only about 80% of those returned, 5% they considered suspicious. And they had, of this whole group, only 3 cancers, and these cancers were in the low-risk postmenopausal women. They had a high false positive rate. Their false positive rate was 4.7%, and they had a low positive predictive value of 6.7. So what they recommend for a biopsy had a low yield of being a cancer. So their technologists performed handheld general screening breast ultrasound to women in the general population of dense breast can aid detection of small mammographically occult breast cancers, although once again the overall positive predictive value is low. So there's some automated systems that I just want to touch on that have these reticulated arms that can help scan patients instead of using a little handheld ultrasound. Here's my hand holding a transducer that's about 5-6 centimeters in length. Some of them have one transducer that's about 15-16 centimeters in length. You can scan the breast in multiple projections. The scanning times may be about a minute. So here you have reproducible imaging instead of one technologist. So what you get are these coronal images. You can get an axial and a sagittal. It's almost like MRI, where you can view the images in multiple planes. Fat is black on ultrasound. Breast tissue is bright, so it's just like a mammogram. Tissue is bright, fat is black. So the idea is that we can look at multiple different slices to try to see things. So here on ultrasound, just some examples. Here are multiple simple cysts, anechoic oval structures with an automated system. Here's an example of a cancer on a coronal image. Here we have this large irregular spiculated mass. You can see it also on the sagittal and axial images as well. This was an invasive ductal. So it just allows more planes for the reviewer to increase their confidence whether something is there or not, and if it is, to be called back for additional workup. There was a study using automated breast ultrasound by Kelly et al. Where they use an automated system and also mammography to look at women with dense breast and high risk in a little over 4,000 patients. And what they found was there about 4 cancers per 1,000 with mammography only, and they increased it an extra 3 by adding that automated breast ultrasound for their cancer detection rate. They did have a higher positive predictive value with the automated system than some of the literature with the handheld. So what about screening of the average risk patient, our plain Jane? There's no data to support the use with these non-dense breast patients. Can be considered in women with dense breasts as an adjunct to mammography. It doesn't replace it. Once again, with personalized medicine, you have to have that balance between increase of cancer detection rate, but also an increase in the false positives that also can be detected. Some states actually mandate these supplemental things be paid for by insurance companies. Connecticut's one of them. Illinois, certainly not North Carolina, but some states do actually pay for these supplemental screening. What about these women at intermediate risk, 15 to 20% lifetime risk? So they've women with these dense breasts may actually benefit with the supplemental screening. So it's certainly an option for these women to have their mammogram plus supplemental screening with ultrasound. Once again, the false positive rates are increased. So once again, a balance between the imaging and the increase in the cancer detection rate. What about the high risk, greater than 20% lifetime? It can be considered for whom MRI screening may be appropriate, but can't have MRI. Maybe they have a cochlear implant. They have a contraindication for MRI. So this is where ultrasound of a high-risk population would only be of benefit. In reality, as more and more institutions get tomosynthesis available for their patients, ultrasound screening kind of has taken a dive in clinical use at some institutions and some locations, but it's something to be aware of. So our poll question is, all of the following are associated with whole breast screening ultrasound except, once again, we're looking for the exception. Number 1, or letter A, not limited by breast density. B, high false positive rate. C, cancer detection rate similar to mammography. Or high positive predictive value is D. So give you a moment there. So all of the following are associated with whole breast screening ultrasound except. Give you a moment there. So remember, it's an except. And for this, due for time, the exception is the high positive predictive value. Actually, whole breast screening ultrasound has a low positive predictive value. All the others are true. They're not limited by breast density. They do have a high false positive rate, and the cancer detection rate is similar to mammography. So the last one I want to touch on briefly is breast MRI for screening. Once again, I showed you this. You have the non-screen, you have screening 1, and you add another layer to try to find cancers sooner before they've spread to increase the prognosis and overall survival of the patient. So MRI, everybody's familiar with an MRI unit. A lot of people don't like to be placed into them due to claustrophobia. But with MRI, we actually use this thing called a breast coil. The patient is actually laying on their belly. My patients have likened these to muffin tins and having their breast put into something. We actually give them a gadolinium-based contrast agent in order to see things. We do multiple different sequences. Depending, sometimes it may take up to 30 minutes to actually do a breast MRI by the time you get them on the table. The advantages of breast MRI is you have this superior soft tissue resolution. It's just like doing an MRI for a brain. You have this multiplanar ability to look at things. High sensitivity, being able to see something very easily. In this example here, we have this oval mass in this right breast on an axial image. It has heterogeneous enhancement. This happened to be a HER2 positive only breast cancer in this patient. What are the disadvantages? One, variable specificity. It sees something very easily, but is it a cancer or not cancer? It doesn't do that great. There are different reasons for it. Perhaps it's the patient's background, the technical methods you may have, and also there's a learning curve for the radiologist. I want to touch a little bit on background parenchymal enhancement. This is the normal breast tissue and how it enhances, and perhaps you're reading a report. So here's the one where there's none or minimal. This is a right breast, this is the left, and these are axial images subtracted. So you can see here kind of the black background. If a mass enhances, you should be able to see it very easily. It's like a fatty mammogram and seeing a mass within it. Here we have a mild background, a moderate where it becomes very busy, and marked. So breast cancers also take up contrast. So you can see when we get into the moderate and marked, there is the possibility we may not see it. It may blend in with the normal breast tissue. There are certain things that we do in timing to hopefully that the cancer will enhance sooner than the regular background for patients. But just let you know, there is variability. The disadvantages of MRI, there is a higher cost. It's over $1,000 very easily at a lot of institutions. There are longer exam times. There's thousands of images for the radiologist to review, and especially if she has comparison studies. You can have a contrast reaction to the gadolinium. I want to touch just briefly on gadolinium since it's making a lot of press. There's something called nephrogenic systemic fibrosis. It is a rare condition associated with a gadolinium contrast medium given to patients with severe renal disease. It's a debilitating disease. It causes severe contractures of the skin and internal organs. It usually presents within 6 months of the last dose of the gadolinium. So moral of the story, don't give gadolinium to patients who have severe renal issues. Gadolinium retention, we will probably be handing out information to patients who have MRIs for all sorts of stuff on gadolinium retention. There is retention of it in small forms. It's less than about 1% of the dose. Most of it's retained in the bones. Tiny amounts of it is retained in the brain. And currently there are no known adverse effects from these small amounts of the retained gadolinium. So breast MRI, you need a request from a physician, approval of the insurance company. It's most appropriate that if the woman has a mammogram in the MRI that they be interpreted together, because a lot of times lymph nodes, stable masses and stuff may enhance on an MRI. So it's nice to have a comparison study and if she has a stable lesion instead of recommending something perhaps from her first MRI. And also for screening MRI, we recommend if they're premenopausal, scan them during their second week of the menstrual cycle when you have the lowest proliferation. So we'll try to decrease that background. So who should screen with breast MRI? It's not recommended for the general population at the moment, too many false positives. So for the women who are at average risk, the plain Janes, there's insufficient evidence to support the use of it at this time. The women who are at intermediate risk, the 15 to 20% lifetime, the American Cancer Society says there's insufficient evidence for or against MRI as an adjunct to mammography at this time. However, there is other literature out there to use in certain populations. The personal history of breast cancer already, women who have had the unfortunate event of being high risk with atypia or LCIS, and I can attest that in our own high risk breast clinic at UNC, there have been patients who have had atypia or LCIS who get supplemental screening also with MRI. So the biggest winner for the special patients here, greater than 20% lifetime risk of developing breast cancer, MRI has a higher sensitivity than mammography in detecting cancers. The combination of mammogram and MRI has the highest sensitivity in this population. Note that the MRI does not replace the mammogram, they're used together. If we look at MRI and mammography, it has a high sensitivity in detecting cancer, almost 93%. Versus ultrasound and mammography in these patients where it's only about 50%. So in this patient population, mammogram and MRI, not an ultrasound. The only time you do an ultrasound in this patient population is if they can't undergo MRI. There's a contraindication. So those who have breast cancer gene mutations certainly should be tested and used with MRI, other genetic syndromes, 20% greater lifetime. And once again, don't forget about these individuals who may have had radiation already in their early teens and 20s. Breast cancer mutation patients, certainly the annual MRI beginning at the age of 25 and then after the age of 30, mammogram and MRI together. So here we have a dense breast, and here just in this dense breast we have an MRI detected breast cancer. This is the irregular enhancing mass. We did something that was called second look ultrasound. So on our mammogram, there was the limitation, we couldn't see it. We could see it with the ultrasound, this irregular mass. Did a needle core biopsy, it was invasive ductal cancer. We did a localization and it came out. So breast MRI is very good at detecting invasive cancer and high-risk DCIS. No test is 100%. Once again, if the MRI is negative, you still need a mammogram. Remember, MRI is a supplemental exam. It does not replace the mammogram. It has a high sensitivity and a lower specificity, so there are false positives. There is an abbreviated breast protocol that institutions are working on. Perhaps we can shorten the exam and eventually use it for the general population and also at a lower cost. So the last poll question, the screening recommendation for a 45-year-old BRCA positive high-risk patient is A, annual mammography and a screening breast ultrasound, annual mammography, screening ultrasound, and MRI, so she would get all three, annual mammography and screening MRI, or just screening MRI only. So once again, this is a 45-year-old BRCA positive patient. Excellent. So everybody is correct. That is the correct answer. The most bang for the buck is the mammogram and MRI. The ultrasound does not add anything if you put all three together, and the ultrasound would only be used if the lady could not undergo MRI for some reason. So the future, personalized medicine. Certainly liquid biomarkers of what we can find in the genetics is going to play a role into perhaps what testing we should or should not have. So in the absence of a known preventable cause, the single most important factor in reducing death and the extent of treatment is early detection through screening. I thank you very much for your time. I know we ran a few minutes over, but I think it's important to present this information.
Dr. Kuzmiak, thank you so much.
Thank you, Tim, for having me.
Absolutely. Let's take a look and see. I know that we're a little over time, but we might have time, if you have time.
I have time for questions.
A few questions here. So again, as long as you already were on Poll Everywhere, you can just go ahead and send those questions in. While we're waiting to see if any others come in, I've had one.
Sure.
How are these being read, and to what extent is technology involved at this point in the reading of this? So is this strictly a radiologist reading that, or is there involvement at this point of in terms of pattern recognition and other computer-aided mechanisms for reading? What's the picture there of that?
It's kind of actually a blend. It's actually a good question. So with mammography in general, we do have CAD systems, computer-aided detection. They're kind of like a second look here, look radiologist.
Right.
Is this a real finding or is it not?
Okay.
CAD for tomosynthesis has a long way to go.
Yeah.
Because there are so many images. There's really not a CAD for ultrasound per se.
Okay.
There are CAD systems for MRI, which are extremely helpful, and with these thousands of images that you're looking at, to once again focus the radiologist's attention, take another look at this lesion. Is there an increase in the sense of blood flow? We actually do kinetic information. So we'll look at how does contrast be taken up and then be excreted by a mass to add additional information, whether it's suspicious or not.
Gotcha. All right, thank you. Looks like we've got some other questions coming in. Is breast pain, perimenopause or postmenopausal women a concern, and can it be skeletal due to old ligaments?
Okay, so breast pain is real, as I tell my patients. If I had a nickel for every patient who came in with breast pain, I could go work at Home Depot or Lowe's in the floral section and not have to worry about the everyday of some of these women who are coming in and fearing for their life. No one really knows for certain in the postmenopausal patients, certainly in perimenopausal. It can be due to hormone influences. Certainly a lot of people who intake in a lot in caffeine can also have increased breast tenderness. Postmenopausal women, I don't think it's due to old ligaments. Even as I hit the magic age of 50 and hitting older, and things are changing as well. No one really has an answer for a lot of women who come in for postmenopausal and they have breast pain. I think the most important thing for these women is be reassured that their imaging studies are negative. The other is also important is a good clinical exam, physical exam, and that's negative as well, as reassure them. Sometimes it's even grandma's home remedies, hot compresses, Advil, Tylenol for breast pain.
All right, thank you. I'll take that next one. Are the talk slides accessible to us? Absolutely.
Yes.
For this and every talk. We have that on the site currently under events with your lecture today. But if you look under past events after today, you'll find Dr. Kuzmiak's lecture information there, including a download of those slides. We also will have the recording, which is accessible, and also the recording for credit for continuing it.
One of the questions that I really like are what causes density? It's breast tissue. So if you want to point the finger at somebody, it's all genetics. So if your mom had dense breasts, you're more likely to have more glandular tissue and dense breasts unless you gain a lot of weight. And if you gain weight, then your breasts will become less dense. And the same if you go on weight loss, you can actually go from a fatty replaced breast to dense.
Okay.
So really it boils down to genetics.
Let's see, do we have time for maybe pick out one or two more, and we should.
Okay, I love this one. How many glasses red wine daily? Well, we're undergoing our mammography ACR accreditation right now, so my technologist supervisor and us may answer that question differently. As for that, I really don't know. I think everything in moderation. It's like patients who come in who are worried about being on hormones. It's, well, what's your cognitive function like? If you can't function without hormones in your life, day to day, I think it's a discussion you need to have with whoever puts you on those, and also with the wine, and make sure that you don't have any other factors, tendencies in families towards alcoholic and stuff. I think everything in moderation is important.
Right. Well, let's leave it at that. I know we are over time. We want to thank Dr. Kuzmiak. Thank you so much. This has been terrific.
Thank you.
We want to thank University Cancer Research Fund, or UCRF. We want to thank the UNC Lineberger Comprehensive Cancer Center, the generous support of the North Carolina General Assembly for UCRF, and then we want to thank Mary King, Veneranda Obore, and John Powell for all the hard work they do to make this and every lecture possible. Upcoming, we've got a medical surgical oncology lecture on June 27th at noon, using biomarkers to plan adjuvant therapy in breast cancer with Dr. Lisa Carey. And then July 11th, our next RN and Allied Health lecture, palliative care opportunities with Nicole Sartor. So we hope you'll be here for both of those. find our lectures online, our recordings, the portal where you can take these lectures for credit. And with that in mind, thank you so much. We're glad that each and every one of you was with us today, and we'll look forward to seeing you at future lectures.
Thank you very much, and if you have any questions, you can also email me directly. My email address is my first name, Sherry_Kuzmiak @med.unc.edu. Thank you.
Thank you so much.